Good morning, everybody. It's a great honor and a pleasure for me to be here amongst you. Thank you very much, Dr. Kavla and Dr. Rajesh, for giving this opportunity to us, and congratulate you for such a wonderful organization of our meeting. And to our senior colleagues, Dr. Deepraj, Dr. Manish Bajal, and the whole team of HSI for this excellent show. What is most impressive is the scientific agenda and the scientific program and the comradeship and togetherness which I have seen yesterday evening, and I can feel from the time the concept of this Congress was taken, and the warmth has brought all of us together once again physically. And I would like to present a smaller aspects of hiatus hernia, which is a little interesting area. At the same time, it has been there for a long time, and a lot of understandings have taken place in this subject. So my time starts now. So we talk about the GERD. I think it is the most forgot disorder, and it is seen in almost 30% of the population, and I'm sure about 30% of us sitting here will be having this problem. And the most interesting part or unfortunate part is that it causes the esophageal condition, what is the Barrett's esophagus, and the survey which has been done endoscopically for GERD, it has shown that all those cases, not investigated, but who have been endoscoped, 10% of they will progress to the Barrett's esophagus. And of course, we are talking about the consequences of Barrett's esophagus, you know, is a pre-malignant condition. Well, I think if we just look a couple of decades back in 1950, as you know, the GERD was considered, it was not a condition. It was only considered when the patient has got the hiatus hernia. That means a patient who has got a hiatus hernia is likely to have GERD, and GERD as such was not considered, and it was required that the hiatus hernia should be repaired only in that condition. But there were two hypotheses in 1980. See, I think, you know, everything looks so recent to us. I think this is a time when we all were starting the surgical career, that in 1980 there were anti-reflux mechanism was started getting evolved, that what is the anti-reflux mechanism. And they said there are two mechanisms. One is the extrinsic mechanism, that those are the cruras which are causing the outside anti-reflux mechanism. And there was an intrinsic mechanism, that is lower esophageal sphincter, LES. So now what I want to emphasize here, that what today we are talking and speaking about crura and LES, these are the very, very recent concept which has changed the understanding of the whole hiatus pathology. What are the extrinsic mechanisms? These are the two cruras which you see. When these cruras get separated to this, and another is the lower esophageal LES. As you can see and try to understand that there is a zone at the lower end of the esophagus and upper part of the stomach, which is LES. Now, something which is I would like to emphasize, which is less understood many times, is the fact of the role of phrenoesophageal fascia. I think we always divide the fascia, but what we have to understand is that it has got two components, and this is what is one of the very important point which I wanted to discuss. It has got upper and the lower mechanism, and this is like a shock absorber. When the food particles are going down, the esophagus prolongs, And when it enters into the stomach, the whole thing comes back again. And this also is one of the pathogenic factors when we are talking of the commonest type of hernia, and that is the sliding hernias. Now, over years, when these things are working, over a period of time, it becomes weaker. Yeah. So it becomes weaker over a period of time, and that gives rise to the sliding type of hernia, which are almost about 95% of the patients. So this is the reason why we should impart, and we see that when the GERD continues for a long time, there could be shortening of the esophagus, there could be intussusception of the stomach, widening of the hiatus, so many other problems come in. So this is the history of this. Now, coming to the type of hernias, we know there are, just a revision of all our younger colleagues. Most common, 95%, of course, is the type 1 hernias, and type 2, 3, 4 are more of a problematic hernias, have more vascular problems like ischemia, maybe valvulus obstruction. And I would just like to have the definition. Now, what happens is that if you see here, there are two elements for type 1 slide. One element is the movement, as I see it, the anti-reflux mechanism moves up, and that is what becomes the cause. But there are two elements. One is the widening of the crura, another is sliding up of the esophagus because of the lexed esophagopharyngeal memory. Of course, when we talk about type 2, but in type 2, you see the junction remains within the abdomen. And this is, I think, important point. It doesn't go up. The part is that the fundus and the other part of the stomach goes up. If you look at the three, the junction has gone up into the chest, and of course the herniation of the gastric fundus, and this is the widening. So this is the difference. The junction has to go up into the chest for it to be there. And of course, the giant hernias, we know that the junction has also gone up, and also the stomach has gone up, and this is the fixed portion. So this portion doesn't go, but along with that, there could be a transverse colon and other structures. In some of the cases, we have seen even a spleen going up into the. So these are the giant hernias which we talk about. Now, the diagnostic modalities. I think sometimes we tend to look at the diagnostic modalities and also see what is important, because a lot of purist approach may not be a functional approach and the practical approach in these cases. Of course, the upper GI endoscopy remains the most essential part of it. And as I said, the person who is doing upper GI endoscopy should indicate where are the landmarks which we talked about, the gastroesophageal junction, and also if a younger endoscopists are doing, they're filling up more gases, the whole things may get exaggerated. So a small hiatus hernia may be reported as a very large hiatus hernia. So that is, as a surgeon, that is the point which we have to see. Of course, when we talk about the manometry, impedance studies, and barium swallow, these are all ancillary process, and CT scan in very selective cases may help us in actually knowing and planning the surgery as such. But I think it's a very interesting point which I would like everybody to sort of put it in their mind, is the inverted iceberg phenomena. See, most of the time in surgery we are talking about the iceberg phenomena. Here it is the inverted phenomena. I think 50 to 60% of individuals more than 50 years of age, when they have their endoscopy, it will be reported as a hiatus hernia. So a report of the upper GI endoscopy, especially a young person with a lesser experience is doing and using more gases, does not become an indication for the repair of the hiatus. And this is where I would like, emphatically, I would like all of you to understand that many times we tend to overstretch, and the moment we see the hiatus hernia, we tend to operate them. That is what the message, only because 9% out of those are symptomatic. And those are the patients which needs to be addressed surgically. And rest, the simple hiatus hernia shown on upper GI is not an indication. So please remember that it follows the inverted iceberg phenomena. Then we talk about the newer concept. I will not like to go into detail because it's more of an academic sort of thing when we talk about the genetic and the biological factors which are responsible. Also the changes in the matrix formation and some of the diseases which are involving the fibrous tissue and the other tissues. I think those are the cases where we see more hiatus hernias. But at the same time, the surgical outcome of those conditions are very poor, and one should be prepared to have that sort of results even after the surgery. Now, a couple of minutes we will spend on the principles of hiatus hernia repair. We must understand that there are two aspects surgically that we have to consider. One is the anatomical repair, that is, of course, the repair of the pleura. And another is the physiological repair, and that is what you take care of, LES, how you are going to improve the competence of LES. Anatomical repair has got again two components. One is the axial component, how the esophagus gets pulled up into the chest, that needs to be reduced, and second is of course the lateral tension. And I would further discuss that unless you take surgically care of these two anatomical repairs, you will have more chances of the surgical failures coming up. So we should take care of these two aspects. Now, anatomical, I think we all know that there has to be more than 2 centimeters and maybe 2 to 4 centimeters of intra-abdominal esophagus, because that means you have brought down the esophagus. And this is where we talk about the short esophagus. I don't know, at least we in our group, we have not believed much on the short esophagus, and we have been doing this surgery. I have been doing for almost 45 years when I started conventional, and maybe 30 years of laparoscopic surgery. But we have not really considered lengthening of the esophagus, and we have not regretted till date. So I don't know how important it is for the concept of short esophagus, but there is a literature which mentions about it. And this reduces the axial tension on the esophagus by getting pulled. Radial tension, of course, is very, very difficult to mention. And that is where we talk, our assessment-wise, we talk about how the laparoscopic visualization of the hiatus looks, whether it is a slit type, or it's a teardrop type, or it's a D type, or it's a oval. I don't really know how important it is, but it also indicates that D type or the oval type will have the very, very wide sort of gap, and the slit type will have the minimal gap, which needs a simple repair. The role of mesh, I think, I would say that initial conventional surgery when we were doing, we were not using the mesh at all. And we started laparoscopic surgery for hiatus hernia almost about 29, 30 years back. And then we started using the mesh. And we were not using the mesh initially. And we realized and published some of the literature, which I'm not going to quote here, which showed a high recurrence of hiatus hernia when the mesh was not used. And also we will confess that that time our dexterity was not there at the hiatus so as to put in a mesh and dare to put in a mesh, not knowing, because there's only one type of mesh which was available. But yes, today I think we can sort of reach to the conclusion. This indication was for Sarfaraz. Yeah, but it's not true. I think you were on time. So I still have time. Okay. So I think now it is quite clear that you can do a simple repair without mesh with just about 3.5 to 4% recurrence. If the gap is less than 10 centimeter, that means basically the slit type of hernias. But as it goes beyond more than 20%, you have to use mesh. Otherwise, the recurrence rate will be very, very high. Mesh repair, I think, as said, for practically all hernias, you need reinforcement, especially when there are moderate to large hernias, as we have discussed. And this area is a little difficult to revisit most of the time because of the adhesions, because of the important structures, especially the esophageal injuries are very common in reoperative surgery. Now, how you are going to use the mesh, I think, again, these are the two conclusions I would like to say, that mesh as a bridge is not the answer in the hiatus hernia. If you are using it as a bridge, because of the diaphragmatic movement and coughing and sneezing and intra-abdominal pressures while passing motion, urine, etc., the mesh will go up into the chest. So, message with this slide is that mesh as a bridge is not to be used in this, and the mesh should always be used as a platform. So you have to approximate the dura and put in a mesh. Even if a bigger gap is left, it is okay. But if you put in a mesh big enough, but the platform is missing, then the mesh will not get incorporated with the tissue, and there will be very high failure. And not only the failure, I think another disturbing fact is the mesh going into the mediastinum and creating problem. So mesh should be used always as a platform. Type of meshes we all know, that is a non-absorbable mesh and all those things. This will, I'm sure, will continue. But future I see biosynthetic meshes are more likely to use in this. And principle of physiological repair, of course, is that restoration of LES is very important. Fundoplication, we commonly have got that fundoplication acts to restoration of LES in the intra-abdominal condition. Of course, Nissen is used for young patients. There is no evidence of motility disorder is a must, because if you do a complete Nissen's fundoplication, and there is even if the minor degree of motility disorder, the patient will become dysphagic, and you will have to undo the repair because they develop esophageal dilatation. Generally, it is agreed now that dysphagia should be reduced, and the age more than 60, 65, and senior patients with a lesser sort of body, this thing, it's better to do a partial repair. And I think we have now concluded in this that both hyatoplasty and fundoplications are crucial to ensure a long-term success for the hiatal hernia surgery. After laparoscopic cholecystectomy, the fundoplication has become the gold standard of the laparoscopy. This is the second procedure has gone, and now we talk, it's a time which has come, 3 decades of laparoscopic surgery. I think we are trying, we should consider, we should think, and we have already moved in this direction, and that is the robotic surgery. This being a 3-dimensional surgery, we have been using the CMR versus robot, and we have done quite a few the fundoplication with great excitement, a great satisfaction, because the 3D images give us a great advantage in this location especially. And we have concluded that fundoplication, LES, and anatomical repair is important. And I bring greetings from our Max Institute, and thankful to my team members for being with us for more than 3 decades. Thank you very much.